We can't hear you, Chris.
Can you hear me now?
Still cannot hear you.
Oh, you can hear me?
You can hear?
I can hear you.
Can anyone else hear me?
Yeah, we can hear you,
Yes,
Chris.
we can hear you, Chris.
All right.
We can hear you.
You.
I hear you.
Hi, everyone.
Hi.
Welcome
Chris.
to the virtual ultrasound course. And we want to start right now. My name is Chris Opon.
I cannot hear Chris.
I'm a residency coordinator of the emergency medicine program in Ghana. We're organizing this in collaboration with the General Hospital, Massachusetts General Hospital in Boston. I think the Division of Emergency Ultrasound, and also they're also part of the emergency medicine department. And I welcome each and every one of you to this wonderful virtual ultrasound course. We think that is going to be very exciting with the pandemic going on around. Right now, we have the opportunity to explore virtual means to enlighten ourselves. And focus or point of care ultrasound being such a great adjunct to clinical decisions, I believe all of us are going to be very, very, very excited about what is going to be done. It's going to be didactics, 2-day didactics, where we're going to have a wonderful faculty. I call it a global faculty coming from almost every part of the world. And we also have a global audience. I'm excited to know that. I wasn't expecting that, but now we also have a global audience and a global faculty virtually from every part of the world. And
I just wanted.
so
And they collect my numbers.
I want to urge each and every one of us to mute our microphones because we have a very, very huge number. So if we don't mute our microphones, it's going to be a little bit chaotic. And I want to hand over to Ike, my co-course director, to take us through what exactly we're going to do today. And I think during the discussions, we'll have time to also do further engagement. Thank you very much. And once again, welcome to the virtual ultrasound course. Ike, can you take over from me?
Yes, Chris, it's such a nice thing to see your face, even though it's virtually. Welcome, everyone. My name is Onyechi Ake. I'm the director of Global Ultrasound in the Division of Emergency Medicine here at Mass General. I'm just going to share my screen so we can go through the course for today. Please mute yourself if you're not muted. Okay, so again, very thankful to Kat for this collaboration, and it's in collaboration with us here at Mass General in the Center for Ultrasound Education and Research. So just a few guidelines, please mute yourselves. We are going to make great use of the chat box for comments and for questions. So during the lectures, if you have any questions, you put it in the chat box and we will be sure to let the teachers know what your questions are. At the end of the day, we have like a few minutes, I think 15 minutes or so, where we can ask more questions and be more interactive. And then there's also going to be a survey at the end of day 1, which is today, and at day 2, and we'll have more information at the end of the course. So this is just the schedule. So we are going to jump in very soon to the lectures. So we're going to have 3 lectures back to back, and then we're going to have a 15 minutes break where you have the opportunity to use the bathroom, stretch your legs, take have a snack, and then we'll finish off with 3 more lectures and have some opportunities for questions afterwards. Okay, so I'm just going to stop sharing my screen. I'm going to hand it off to our first lecturer of the day, Andrew Leteplo. Andrew Leteplo is the chief of our division here in the Division of Ultrasound at Mass General Hospital. He's a world-renowned lecturer and researcher. We're very grateful that he's giving us this lecture today. I'm going to stop sharing so that Andrew can give us all his wisdom.
The host is not allowed participants to unmute themselves.
You're unmuted now.
There we go. Can everybody hear me? Yeah? Okay, good. I probably actually can give you all of my wisdom in 25 minutes because every year it feels like there's less and less. And also, sorry for my N95 mask face. I just left the emergency department, but I'm very excited to be here to kick off this course. And I think we're all very excited about this. And thank you, Dr. Eke, for organizing it. And let's start out with the best thing there is to talk about with ultrasound. Let me share my screen. Cool, is it playing? Looks like a slideshow. Fantastic, all right, so far we're working. We're gonna talk a little bit about an introduction to point of care ultrasound. And specifically what we're gonna talk about is what is POCUS, right? Point of care ultrasound is the term we use around the world. Why POCUS, what are the advantages? A little bit about how ultrasound works, some scanning modes, vocabulary, how to acquire pictures, and then some artifacts. So this is kind of very brief introduction to ultrasound. When you want to know what's going on inside a body, there are multiple different options for imaging, right? And they vary by largely these characteristics here. Portability, how safe they are, how easily reproducible it is, dynamic, inexpensive, and how's the image quality. So X-ray's not bad, it's pretty portable. Let's show it. Colored pencils. I'm hearing that there's, oh, huh. Yeah, let me close that. Maybe that's bizarre, but how about now? The colored pencils are gone? I always liked it. Yeah, I like drawing. So sometimes it's just nice to keep colored pencils around. Anyway, so X-ray is pretty good. It's portable. There's some radiation. It is not dynamic, meaning that it is a single moment in time. It is fairly inexpensive. The image quality is good to very good, but depending what you're looking for. CAT scan is not as portable, is more radiation, harder to get in some settings, but the image quality is better. But there are a lot of negatives of it. Now, the MRI is even more expensive, has better image quality, and it does not have radiation. So that's kind of a win there. But ultrasound is the real winner. Ultrasound is completely portable. It is safe. It is very easy to reproduce. You just do it, put the probe on the patient again. It is dynamic, meaning it'll tell you exactly what is going on. You can see, it's the only one of these modalities where you can see motion. It is inexpensive. And the only variable is the image quality. And that image quality is dependent on the user. And that's you. So you guys already are far ahead of the game because you're here. And thank you for your interest in ultrasound because we love it. And it is our goal here at Cure to save the world one ultrasound at a time. And so the more of an impact we can have, the broader reach we can have, the better. So yes, ultrasound is user dependent. You'll hear that term, but pretty much everything in medicine is. Whoever's using the stethoscope, that's also user dependent. Whoever's reading the CAT scan, that's user dependent. What are the benefits of POCUS? There are many of them. And just a quick summary, we could talk hours about every one of these and what the data shows, but there is evidence showing all of these things. It is more accurate than other tests. There are less complications if you use ultrasound. You will improve your throughput. You will save lives. You will decrease radiation. Patients will be happier. It will decrease your costs. It will improve outcomes. And there's a decreased need for referral or sending someone to a regional hospital if that's what your practice pattern is. There are so many benefits, and there are so little downsides that it's kind of the best thing in the world, I think. So point of care ultrasound also has some other names. There's emergency ultrasound, focused ultrasound, bedside ultrasound, clinician performed ultrasound, and limited ultrasound. And I want to just draw attention to the last one, limited ultrasound. It is not limited in quality. It is limited in scope. So we're trying to answer a single question, right? And inherent in all questions that we ask with POCUS is we have a yes or no question, and then we answer it, and then that factors into our clinical decision making. Traditional ultrasound imaging. The clinicians have a question. What do? They order it. The patient goes over, a tech does the image acquisition and gets the pictures. They send those images to a radiologist who then interprets the images and then sends you back a report. And then you decide what to do with the report and integrate it clinically. The benefit of point of care ultrasound is that it's all of those things together. You acquire the images, you interpret them, and then you integrate your findings immediately into patient care. I made this up, but I think it kind of makes sense. The idea of stewardship, of appropriate use of ultrasound, is one that's probably not talked about enough. And same thing, we could talk for a long time about this, but I would offer the following. If doing an ultrasound is unlikely to change anything, well, then don't bother, right? That is your time that you're spending on a patient. And if it's not going to change anything, don't focus. If it would change your medical decisions, then you probably should focus, because why wouldn't you? It's essentially risk-free. And if those decisions are time sensitive, then you must focus. How does sound work? Generally, there's a source, such as this little speaker, and then there's a receiver. And the sound wave goes and it hits, and then when the sound hits the receiver hears it, and that's called hearing. Human hearing is up to, the frequency is up to 20,000 hertz. Medical ultrasound is 1,000 times higher frequency than that. And so here's your probe, and the probe acts as the source. And it sends out a signal, and that signal goes and travels, and then it hits an object. It bounces off the object, comes back to the probe, and the probe is also the receiver. Now, there's a property in the ends of probes called the piezoelectric property. There are these crystals here. And what happens is that they can transduce voltage into vibration and back and forth. So what happens? So the machine sends an electric signal, voltage, crystal vibrates, causes a sound, an ultrasound, goes down, hits an object, and it comes back. Another crystal's excited, and now it hits this object, but this object, it hit quicker, and so it came back more quickly. And so the probe translates that into depth, right? And then the strength of returning signal is also translated into brightness, right? And so what you're seeing here is that this one took longer to come back, so the probe knows it must be deeper, right? So time of flight, the duration of time that it took to hit this object translates into the depth. The strength of the returning signal translates into brightness. And those really the only two things you need to think about when you're talking about taking pretty pictures, depth and brightness. Now, every one of these crystals is going, and it sends a quick blip of a signal. And the stuff that comes back earlier, it puts up here. The stuff that took longer, it puts down here, right? And again, the strength of returning signal, it translates into brightness. Its neighbor, this crystal here, it does the same thing, and so on and so forth. And what you can see is that with time, an image of this carotid artery and compressed IJ is generated. That's how pictures are made. All right, a couple modes. B mode, the rest of this is going to be vocabulary and talk a little bit about artifacts. And if you pay attention and you start using these terms, you will sound very bright. Like your gain is too high. That's like a dad joke. Sorry, I couldn't resist. That's a new one, new joke. All right. B mode stands for brightness mode. And that's typical imaging. You can do everything that you need to do for emergency POCUS with just B mode. M mode looks at, M stands for motion. And M mode looks at a point along a line over time, right? And so this y-axis is the depth, and the x-axis here is time, right? Essentially, we're taking just one of these crystals, and we're seeing what's happening over time. For color mode, we can actually see flow by looking at the Doppler signal. And Doppler mode, we can actually quantify that flow. Again, those are not necessary for almost everything we do. I rarely use either of them, honestly. Okay, now a little bit of terms. Echogenicity refers to how bright something is. If something is echogenic, then it will be really bright, like bone. If something is anechoic, then it will be black, like fluid. And we know that black means fluid. That's one of our helpful tips when we're looking at an ultrasound image to know what's fluid or not. Hyperechoic, hypoechoic, isoechoic are relative terms that you can use when you're talking about two different structures and how they relate to each other. You wouldn't say this is brighter than that. You'd say this is hyperechoic when you compare it to the kidney. Okay. There are different probes that we use, and the most commonly encountered ones are these three: curved, curvilinear, phased array, and linear. You can always tell, because if you flip these around, you can see the footprints. We call this the footprint, the part that touches the patient. And the footprint here matches the footprint here. The phased array is kind of like a point. This is a sector. And then the linear probe is linear straight across, and you look at the top straight across. So if you're ever trying to figure out which probe was used, you just look at the top of the screen at the shape of what's at the top of that sector. Generally speaking, the linear probe has a higher higher resolution. You'll have prettier pictures, but what you lose is your penetration, so you won't be able to see as deeply. Every probe has a probe marker, and this one you see it right here. If you're not sure where your probe marker is, you just put a little bit of gel on one side of this probe by the footprint, and you'll see that immediately this is the side. It is important to note that this right here is the probe marker, which side it correlates to, because that's how you're going to have correct orientation. Generally, we're scanning things in 3 main planes. This is the sagittal plane, right? We're cutting through the body. And so what you'll see here is head is over here, feet are over here, and this is someone's aorta with a terrible dissection. Here is a coronal plane, right? We're parallel to the bed, and this is like a fast exam. And then here's a transverse plane. We're looking at an aorta here, but now in a transverse view. This looks like a CAT scan. Generally, the convention is you put the probe marker toward the patient's head or to the patient's right. And that will cause the images here to align the way that it would on a CAT scan, with things on this side of the screen being the patient's right, things over here being the patient's left. There are some movements that you need to know about. We won't be doing any hands-on today, but at some point you will, and you'll be guiding somebody, and you want to use these terms. So when you're fanning, you're not touching what part of the probe, you're not changing what part of the probe is touching the patient. You're just kind of moving back and forth in this direction. And then rocking, same thing. You're not changing what part of the probe is touching the patient. You're just moving it back and forth in this direction. Sweeping, you're not rotating the probe, you're just moving it. And sliding, you're moving it in this direction along the y-axis. And then the 2 motions within the z-axis are rotation. Again, you're not changing what part's touching, you're just twisting the probe. And then compression, you're moving up and down in the z-axis. So here are just some examples. This is fanning. You can imagine a fan. This is sweeping. You can imagine a broom. This is rocking. And you can imagine a beautiful blue rocking chair. Part of taking good pictures, this is really a photography course, and that's how I think about the ultrasound machine. It's just a very special camera that you can look inside of a body. And if any of you like photography like I do, fancy cameras like this can be quite intimidating because there are so many buttons and they look really scary. But you don't need all of them. And what I want to do is kind of dispel the myth, because people get, what would you call it, button phobia, and they get intimidated by it. How can I possibly do this correctly? I don't know how to use all those things. You don't need to, right? This is a cockpit of a plane. You don't need all of the buttons, probably. I'm not a pilot, so I don't know. And I don't mean to take away how hard flying is, but you probably need the takeoff button, the don't crash button, and the landing button. You probably don't need all of them to just, stay alive. What do you need for an ultrasound machine? You need the power button. So familiarize yourself on your machine, and we know that everybody's got different machines. You need to know how to turn it on. You need to know how to change the probes. Some machines have these, this is called a transducer, triple transducer connection or something. And you can just push a button and select it, and that will be your transducer. Machines, I think more commonly now are having a software-driven thing, so it might be on a touch screen. But for every machine, familiarize yourself how to change a transducer. You may need to manually connect and disconnect it depending on the age of your machine. Depth is very important. So just focusing on depth and gain are your key to taking good ultrasounds. So you want an appropriate depth. You don't want to be too deep. Like on this picture down here to the right, this is an aorta. This is a waste of space. I'm not interested. This is vertebral shadow, great. But I'm just looking at the aorta. I don't want it all the way here, right? This is kind of a better picture in the middle. This is like Goldilocks. And then here, this is actually pretty nice also, but maybe a little too close. I'd like to see a little bit of the surrounding tissue. And without this nice shadow here, I can't necessarily tell you that this is definitively vertebral shadow. You want to show everybody where you are in the body. This is a cardiac view, but the entire heart is all the way up here, right? You don't need all of this. This is a waste of space. And then brightness. Gain is a word for brightness. So don't say turn up the brightness, just say turn up the gain. And so here you can see what happens when we are turning up the gain and then turning down the gain. It gets brighter, it gets darker. And then everybody's got a little bit of a different feeling for how bright they like it. I kind of like to overgain things because I feel like you probably miss a little bit less. Besides that, you need to know how to save pictures because documentation of images is an important thing also. So you need the freeze button, store. So like sometimes it says clip, sometimes it says save. And then the caliper button can be helpful if you need to measure the size of anything. Okay, the last part here is we're going to talk about some artifacts. Now remember, as wonderful as these machines are, they are machines and they do not have brains. And so they rely on a couple properties of sound. One of those properties is that sound always travels in a straight line. And here, what we see are, so the first artifact we're going to talk about is shadowing, right? And so what happens here is that these gallstones are so hyperechoic, they reflect all of the ultrasound beams. Remember, sometimes the ultrasound beams pass through structures, but here they get all reflected. And so there's no sound coming from back here. And so the probe doesn't know any better. It doesn't get any signals. It makes it all black. And this looks like shadowing. So when you see shadowing, that's your friend. You know that means that there's something that is very hyperechoic. Bones shadow, gallstones shadow, things with a lot of calcium tend to shadow. This shadowing down here is a little different, right? You can see here, these are bones, by the way, on the ribs. We're going to talk about lung later and then tomorrow because it's the best. Here's white shadowing, and this white shadowing like that means air. There's some sort of air in that area. This is dark shadowing. It means calcium. There's reverberation also. So sometimes ultrasound beams, they get caught and they echo back and forth. Like this is a comet tail artifact at the pleural surface. There's ultrasound beams are reverberating here at the pleural surface, and they're bouncing back and forth very quickly. And so what is generated are these multiple parallel horizontal lines. Here, this is probably soft tissue. You may see this with a needle. You may see this with a foreign body, such as metallic things for central guidance. You'll see it if you're putting in a central line or even sometimes a peripheral IV. This is reverberation artifact. Posterior enhancement refers to how bright something is immediately posterior to a fluid-filled structure. This is somebody's bladder, and the gain's a little too high, but you can see it's really, really bright here. It's too much. And that's just because there's no attenuation of the strength of the image as it's passing through the bladder. So it's emerging here with the same intensity that it had all the way up here. And the machine normally accounts for that. So this is called posterior enhancement. It is your clue that a structure may be fluid-filled. The way to get rid of it is just turn down the far field gain. There's something called edge artifact. Remember, this looks a little bit like the shadowing that we talked about, but there's nothing bright here. That's one way to differentiate it, right? There's no gallstone, there's not a bone, there's no calcium that's causing this blackout. This has to do with refraction. So those of you who remember learning about light and refraction, if the classic example is the pencil in a glass of water, and if you look at it from a certain angle, the pencil looks broken. Well, it's the same thing with refraction. When you have a curvilinear structure, like the walls of vessels, like this carotid, or this is an eye, this is an eyeball with a retinal detachment here. At the point where that curvilinear structure gets vertical, then you see a dropout of sound. So this is normal from rounded structures and the edges. It's called edge artifact or artifact by refraction. It comes down. You have this loss of image there. And then there's the mirror image artifact, and this occurs at brightly reflective surfaces such as the diaphragm. So what you'll see here is the sound beam comes and it bounces off the diaphragm and it comes this way like a mirror, and it's hitting the liver. Now, just like with the other sound, it's bouncing back and it's coming this way. And so that machine is coming back to the probe. It took longer than just this regular duration. So the probe thinks that it is deeper. And also, remember I said the ultrasound machines assume that sound is coming from a straight line. It sends something out in this direction, it's coming back, that object must be down here. So essentially what it's doing is everything over here is bouncing off and it looks like a mirror image artifact here. You'll see this at brightly reflective structures such as diaphragm when the other side of the diaphragm is filled with air. That's foreshadowing, more on that later. This, for example, is when you have pleural fluid. This is not air. And so when there's no air here, the diaphragm is not acting like a mirror, and you actually see the fluid, and you can see the spine sign here. Okay, cool. So in summary, big picture is POCUS is your friend. Congratulations to all of you for being here and for wanting to be here and for wanting to learn how to use this invaluable tool, because it's really amazing. You need to know not only how to get the pictures, you need to know what the indications are. You need to understand what the focus clinical questions are. So for every one of the talks that you're going to hear about cardiac or lung or IVC, make sure you understand when you should do it, why you should do it, when you shouldn't do it, what your focus question is that you're trying to answer. We are not looking at every single hepatocyte when we're doing a liver ultrasound. We're answering a simple yes or no question. We're not looking at every part of the heart when we're looking at doing a cardiac ultrasound. There are just a couple simple yes or no questions. And then practice. The beautiful thing is that you have the ability to practice. If you have an ultrasound machine, you can learn by yourself. And one way to do it is anytime that your patient is getting any sort of additional imaging, well, put the ultrasound probe on and see if you can answer the question. You're worried about a pneumothorax, somebody's getting a chest x-ray or a CAT scan, take a look and answer for yourself. Write it down, make a log of all of the scans you're doing. Say, I think this patient had a pneumothorax because I saw lack of lung sliding. I followed up on the CAT scan and there it was, there's a pneumothorax, and you will build your own confidence that way. And it's an amazing tool. You can really, really help the patients a lot, especially if you work in resource limited environments. It's pretty amazing. So that's all I got. And I think I have a couple of minutes for questions, or are we good?
Thank you, Andrew. Yes, so we have a few minutes for questions, like 2 minutes or so. If anybody has any question, feel free to put it in the chat box and we'll try to answer it. If not, while we are waiting for the questions, I think we'll head off to our next presentation.
Great. Thank you, everybody. I hope you enjoy the course, and I will see you tomorrow.
Okay, our next presenter is Dr. Ahad Al-Saud. She is a senior ultrasound fellow here. Ahad is also a faculty back at Saudi Arabia. She also is like the director of NASCA equivalent in Saudi. So she's a big deal. We're very glad to have her. And she's going to be presenting about a cardiac ultrasound. Andrew, thank you so much again.
Hello, everyone. We're going to start. I'm just starting the share screen right now. Hopefully it's showing clearly and you can hear me very well, hopefully. Thank you so much. My name is Ahad Al-Saud. I'm going to talk about the cardiac ultrasound and the 4 views and the 3 E's. So to start, I have no conflict of interest and nothing to disclose here. And our objectives is to learn the 4 basic views of cardiac ultrasound and how to scan them, identify the cardiac structures on ultrasound, and the 3 E's of cardiac ultrasound. So initially, when you start with picking your probe. So most commonly, everyone that uses a cardiac study, they would go with the cardiac phased array probe. But occasionally, sometimes in the case of trauma or if that's the only probe you have, you could use the curvilinear abdominal probe, but the image quality would be suboptimal. an important point to start in knowing is that as Dr. Latepal said in the first presentation, the markers are very important to know where you are and so that you could know where it's oriented. We have a cardiology view and we have the point of care ultrasound or the focus or POCUS bedside ultrasound that we're doing. So if you notice here, this marker is on the left side of the screen. And when you see that left side of the screen, that means you hold your probe marker towards the right side of the patient. The same thing with the cardiology. So if you see that dot up there, make sure that you're well aware of how to orient it. And that right dot there means that the probe marker is to the left of the screen. This will be very important because we'll discuss how that would affect in differentials with the RV dysfunction and left ventricular sizes. So we start with the four basic views. The four basic views, we have the parasternal long, the parasternal short, apical 4, and the subxiphoid. As you can clearly see here, the parasternal long axis starts, this is the sternal notch, and you go right next to the sternum with the marker pointing towards the left hip of the patient. And then to get the parasternal short axis, you turn and rotate that probe 90 degrees, pointing the other side. The subxiphoid can be done with a phased array probe or the curvilinear, but the way to approach it is to apply pressure on the subxiphoid just below it and flatten your probe so that you could see right under the diaphragm. The most difficult view that's usually done here is the apical 4. A lot of people struggle with it, but the concept is you have to look into the heart at the apex, dissecting it in the middle at the coronal plane, showing all the 4 chambers. So these are the basic views. And this is just a summary to show you here how those views would represent and what are you looking at related to the anatomy. I'll make a clear picture here. So those 4 views are generated from three spots on the body. So the parasternal has 2, long and short, and then the apical 4, and then the subxiphoid, which is also a 4-chamber view. Let's start with the parasternal long. I just want to make it just apparent here that when you're doing when we're looking at the structures here, you're dissecting the cardiac chambers in the same plane of the axis of it. We're dissecting it in that plane, and what we see is the right ventricle starting from the top, right ventricle, and then we go below that with the septum, and then we see the left ventricle, and that's on the right side, the aorta and the left atrium. I'm going to go into more detail. You want to get this view while the patient is supine between the 2nd and 5th intercostal space, depending on how large the size is. And you want to get the best view that you can. And that's meaning the middle of the screen should have the mitral valve, and you have 1/3 of the screens on the side is the right ventricle, the aorta, and the left atrium. This is an excellent view to get left ventricular function, an aortic outflow tract, and the aortic roots. These are some images that I'm going to show you right now. You can see here, we could identify these structures here. That's the right ventricle. That's the aorta, left atrium, and left ventricle. The RV, remember, the RV is the most anterior. So when someone gets stabbed, that's the first part that gets injured. So again, the rule of ones is like these structures right over here are approximately the same size. If there's anyone that's showing a little bit larger or disproportionate, kind of investigate that. But let's go for for seeing a very important structure. There's this structure right here, a circular hypoechoic area or structure that's here. This is the descending aorta. This is very important so that we can differentiate pleural effusion from pericardial effusion. We'll go to the next view. To get to this next view, first of all, you just have to turn 90 degrees clockwise from the parasternal long. And if this was facing that angle. This is the alignment. It's going to be this way. And the way you see it, it's the same spacing, the second to fifth intercostal space with, again, an extra point, which is you cannot, it's a short axis. You're cutting the heart in half and you're showing these circles. These circles represent the left ventricle and the right ventricle, but there are levels for it. So this is very helpful so that you could know which area you're looking at. It's good. It's an excellent view for the contractility of the cardiac and the global function of the left ventricle, and comparing right ventricular size to left ventricular size. So I summed them up here. So if you're high above, right over here, you can see that you get this view, which has the aorta in place and the RV outflow inflow tract. This is a little bit advanced, but then if you go lower, you're in the middle zone here. You're right at the level of the mitral valve. And then if you go lower below that just a little bit, this is the best picture or best site to have an assessment of the global ventricular contraction and how the heart is squeezing. And that's at the level of the papillary muscles. We go into much detail. So this is what they call the Mercedes sign, because that's where the level of the aortic valve is. And this is an interesting view because you see the right atrium here going to the right ventricle. This is the tricuspid valve. This is the pulmonary valve, and this is the left atrium. If there's any clot going here, sometimes you could see, and you can see it dilated too. But that's, again, it's one of the advanced view. The secret is to fan, and even when you're fanning, this is at the level of the mitral valve, the fish mouth view. It looks just like a fish. So this also tells you about the contractility. You can see this is the LV, RV is here. And the money maker here is this view, which is at the papillary muscles, the anterior lateral and the posterior lateral. This is where you really assess for global contractility of the heart. You want to, if you have the dilated RV, if it's affecting the septum or pushing on the septum, it'll show in this view. Then we go to the apical 4. Apical 4 is one of the difficult views to get. It usually is because the orientation of the person scanning is they're used to the parasternal long and parasternal short 90 degrees twist. But if you think about it, there's also a way to get it. It's like you're instead of dissecting the whole heart 90 degrees like in the middle, you're dissecting it right in the middle and at the longitudinal axis of it. So it's like, it's going to be the whole flow of everything. You could see the whole chamber, the 4 chambers, left ventricle, right atrium, left ventricle, and all the mitral valves. This is an excellent view to compare the relative chamber sizes. Again, if you're having difficulty to get this view, the trick is to let the person lay in the left lateral decubitus, and this will help make the view, or get rid of a little bit the lingula from the lung there, and you could see the views better, and you could make the septum more vertical. This is what you get in the 4-chamber view. I put a little arrow right here is to remind everyone, know your orientation, because this is very important. If you flip this and this was actually the right ventricle, then you get into trouble. And you'll miss a person that might have PE and miss thrombolytics. That's why it's very important to have that marker in your orientation. So if the marker is on the right side of the screen, the probe marker is going to be pointing to the left side of the patient. If the marker is going to be on the opposite, it's going to be the opposite. Just to stress on the levels here, these are when you have both of them, both valves are at the same level, and you could see both leaflets here, and the septum is right in the middle. That is the optimal view for the 4-chamber view. And the last view here is the subxiphoid view. Subxiphoid view, as I stated, it's placed just inferior to the xiphoid process. The probe marker is at the patient's left side if we're using the cardiology preset, and it's going to be on the right side if we're using our focus point of care abdominal preset. And the liver lobe is used mainly as an acoustic window. And this is very important to stress on, because that's how you know, and it's the barrier that shows you the better view of the heart as a fourth chamber. When you're putting the probe on the just below the xiphoid process, make sure to just fan a little bit, and then once you see that area, just flatten it down, and that will make you have a better view for the four chamber subxiphoid view. And this is the representation of what you're seeing. You can see the liver right here. This is the heart. And you see, this is what's anterior, which is closer to the liver, is the right side. So this is the right atrium, right ventricle. This is the left atrium, left ventricle. So we go to our next section here, which is, what are the 3 E's? The 3 E's are what questions that we need to answer. One of them is like, does the patient have a pericardial effusion? Or how is the patient's ejection fraction? Is this patient coming in a cardiac arrest? Does he have contractility? So that's showing you what the ejection fraction is. Are the ventricles equals in size? So emergency echo solves many problems in the clinical setting, from cardiac arrest to shortness of breath to chest pain, unexplained hypotension, and syncope. So we're going to go by each one of them, and hopefully it's not going to be that long. So pericardial effusion, we have mainly, we can see them in any view, in every view, honestly, but there are certain pointers onto where these views are the best. Subxiphoid view, the fluid collects between the right side of the heart and the liver. So that interface between the heart and the liver gets filled with a hypoechoic area representing fluid. The peristernal long axis, you could see the fluid in the anterior portions and the posterior portion, but be very careful at looking at the posterior wall to not mistake it with a pleural effusion. And the trick is, pericardial effusion has the fluid going anterior to the descending thoracic aorta. In the apical four-chamber view, you see the fluid on the lateral aspect surrounding the whole heart. Oftentimes, they're graded by the size, and they use the largest pocket of fluid that is visible in diastole. Just to sum it up, the magic number is 1 here. So it's if it's less than 1, it's small. If it's more than 1, it's moderate. If it's definitely more than 2, it's going to be large. And that's measuring the fluid from the pericardium to the myocardium. One of the pitfalls that people miss here is the physiological fluid. Physiological fluid is about 50 to 100 ml sometimes, and these are just present there, but it could be mistaken as epicardial or pericardial effusion. Epicardial fat pad is the fat structure right anterior to the myocardium. It moves with the myocardial tissue. It doesn't act like fluid, and I'll show you a lot of images right there. And sometimes clotted blood would be apparent, especially post-surgical interventions or traumas. So in this view, I labeled what you clearly see. Pericardial effusion goes all around the sides here. You can see this hypoechoic area here. And I marked the descending aorta so that you could see this is anterior to the descending aorta. And when you look here, the patient also has a pleural effusion. And the pleural effusion continues, but it stops at the aorta. It does not pass or crosses the aorta no matter what. So just to show you even more, the parasternal long axis here, you can see this is hypoechoic area. This is that pericardial effusion anterior to the descending aorta. Another image here with the four-chamber, you could see the fluid all around the heart. This is a short axis. It's globally around the heart. And this is the subxiphoid. This is the liver, and this is the pericardial effusion right there. And if you notice, you can see the fluid also going downwards here. Cardiac tamponade, I need to stress on it as it's a clinical diagnosis, but there are echocardiographic findings for it. Right atrial inversion during ventricular systole is more common, and it's one of the earliest signs. Right ventricular free wall inversion is during ventricular diastole. It's less sensitive, but it's more specific. And tamponade depends on the rate of fluid accommodation. The more rapid it is, the more critical it is. But if it's chronic, sometimes it's not, the person is not affected. And then this is a representation of what I'm trying to explain when I'm telling them that this patient is having tamponade. When you see this man jumping on the trampoline, and if you can imagine with me, he's jumping right here. So this would be a cardiac tamponade with ultrasonographic finding, but it depends on the clinical setting if he developed this chronically or is impending to get worse. It's all clinical context. The other image here, you can see again, just imagine there's someone jumping on a trampoline. This is cardiac tamponade with ultrasound. Fat pads and clots. So this is a patient that got into a trauma, and you can see that there is a hypoechoic area here, but it's kind of more gray than black. It's not like the fluid in the ventricle here. So this is a clot surrounding the heart. Right here, this is a subxiphoid view. This is the liver, and this hypoechoic area that's a bit grayish. It's small, I know, but it doesn't go around the heart. That's a fat pad, and it's also moving with or going with the movement of the myocardium. This is also another example of a fat pad in a short axis view. You can see it here. It doesn't continue, it just gets cut off. For ejection fraction, the global ventricular function is what we look for. We want to assess all views, all planes. You assess the degree of the motion of the wall and the thickening in each view as much as possible, because you need more views to assess how good the heart is. The classification of left systolic function is hyperdynamic, that's more than 70% ejection fraction. Normal is 50 to 70, depressed is 30 to 50, and severely depressed is less than 30. We use a subjective assessment, which is eyeballing. It's a little bit limited. It's one of the limitations. Quantitative is more accurate, but the major pitfalls is here when there's irregular rhythms or extreme heart rates like tachycardia. You cannot have an accurate assessment, or you cannot really eyeball how much that cardiac function is working or not working. Experienced observer in one of the study compared them to trackball measurements and found that they had a sensitivity of 82 and 86 specificity. The quantitative assessment is something called EPSS, endpoint septal separation. It's a little bit advanced, but I will show you an image of this. So what you kind of look here, you look at the contraction of the muscles here, and then we look at the contraction or the thickness of the muscle here. And the red zone here, this is where we drop an M mode here, and we measure the septum and the anterior leaflet. If it's less than 7 millimeters, that's normal. If it's more than 10, it's depressed. And if it's been between, think about clinically correlating it. But in the fast way, the way we're going to do it is that see if it's not hitting, that's the poor man's assessment for this person's having a depressed ejection fraction. These are a couple of images. On the right side, this is a normal heart comparing to a low ejection fraction. You can clearly see that this anterior portion is not hitting the septum at all. And the contractility is poor. This other image here, this one is very subtle. If you really look at it, it's not really that much of a decrease. So it's just to show you the different levels of depressed ejection fraction, but this would not be considered as severe, but it's a little bit reduced. This is apparent when you're using the short axis view. This is a normal cardiac contractility, and this is a person that's having heart failure and decreased ejection fraction. Another assessment here is with the 4-chamber views. This is a normal beating heart. This is a heart that's having low, severely depressed ejection fraction. There's the other component of hyperdynamic circulations. This usually gives you a hint that the patient lost a lot of blood or is hypovolemic or is needing fluids, and you need to support that volume. These are the 3 views, the apical 4, the parasternal long, and the parasternal short. Cardiac arrest, it's useful to know if you're having cardiac arrest. This person is having complete cardiac standstill. There's nothing there. This person has PEA on the scanning. So you can see a little bit twitching there, but there's no contract. It's not perfusing rhythm. And this person was after resuscitation and had a little bit of a contractility. And these will all change the management. Finally is the equality. The equality is to assess the RV dilatation or if there's any right-sided heart strain. Apical four chamber is the view to go. The normal ratio is the RV to LV ratio is 0.6 to 1. It's usually measured like this from the apical four chamber across the tips of the aortic ventricular valves here. My tip for you is to use the cutoff 1 to 1 because you're eyeballing it. So if you do this scan and you see both images and they're equal size, then that's a little bit of a hint that, okay, maybe the RV is bigger, but it really shows if it's larger, definitely like this one here that's presented to you. This in a clinical setting, you have to really be aware of this, especially when a patient has a suggestion of PE. So RV dilatation is suggestive for the diagnosis of a PE. And these are examples of really dilated, if you can see right side, this is the ventricle, look at this. This is the left side, it's smaller. This is at least half. This one is really half. This is ballooned. You could see even the right atrium is enlarged. One of the famous signs that people use too is the D sign. That's the septal flattening of septal wall into the left ventricle, what is called the D sign. There's also a lot of talk about McConnell's sign. And this is the hypokinesis of the right ventricular free wall while preserved movement of the apex. In the end, it doesn't, the normal chamber size does not rule out PE, so you have to risk stratify this. So summary, I want you to go home and when you go to your next clinic, incorporate echo into your workup. If there's any chest pain, shortness of breath, hypotension, cardiac arrest, use the EEE for answering and figuring out what's the problem. Does the patient have an effusion? What's the ejection fraction? And are the chambers equal or is there any discrepancy? Confirm or refute. It's not always confirming your findings with multiple views. Practice imaging in as many views as possible. It's always beneficial for the patient. Know your limitations. Knowledge is only a limitation. So your goal is to be specific, not sensitive. Thank you so much. And you can scan this QR for the references used for this lecture.
Thank you, Ahad. Thank you. That was like very, very concise, but very like, how would I say? It was like a perfectly gifted box, very thorough. So thank you for giving us that amazing talk. Does anybody have any questions? Feel free to put your questions in the chat box. And while everybody's still thinking of their questions, I know there are questions there. Don't be shy. Feel free to send them in. And even if we go to a different lecture. But now we are going to transition to our last lecture before we have our break. This lecture is going to be given by Dr. Kathleen McFadden. Kathleen is one of our current fellows here at Mass General in the Department of Emergency Medicine in the Division of Ultrasound. She's an internist, so she's actually an internal medicine doctor who is doing her fellowship here with us. She has a love for coffee. We are very lucky to have her. She's also the most compassionate doctor I have met. So I'm excited to hear her talk.
Thank you, Onye. That was a very kind introduction. And thank you everybody for being here today. I'm really excited to be talking to you about inferior vena cava ultrasound. I think this is nicely timed after the lecture by Dr. Al Saud, because we will be discussing how inferior vena cava ultrasound is one small aspect of clinical ultrasonography that we use in the point of care setting that can really be helpful only when it's used in the setting of other modalities. Both the lecture that come before me and the one that comes after me will help you as you think about how to use this tool effectively. I think somebody may have written on the screen. I'm not sure if I have the ability to clear that off, but regardless, you should still be able to see my slides. So to discuss the inferior vena cava is to understand some of the basics of the physiology of intra-abdominal vessels. And the first and most important thing to recognize is that about 70% of venous return lies within the inferior vena cava because it is a capacitance vessel, meaning that it's very susceptible to everything around it simply by nature of the fact that it's very distensible, it has a thin wall, and it's highly compliant. But what that means is that almost anything around it can impact its diameter, its appearance on ultrasound, and its function physiologically, whether that be intra-abdominal pathology, cardiac pathology, such as tamponade, which will drive back pressure into the inferior vena cava, or local and structural factors can really have a lot of impact. So this makes this vessel, while something easy to find, quite vulnerable to both pressure and volume changes. One of the things that makes it helpful for us is that it's very closely approximated to the right atrium, which means that theoretically it should be a surrogate marker of the right atrial pressure, the central venous pressure, which can be helpful in the setting of thinking about resuscitation. And so essentially what we know is that we have a large vessel that's thin-walled. It's very susceptible to a lot of changes, and that means that anytime we obtain images of it with ultrasound, we have to be cognizant of the other factors that may be influencing the way that it appears. Here on the right side of the screen is just a picture of the inferior vena cava, but we'll be going through a lot more details in terms of how to identify it and how also to understand what it means when you look at it in the point of care setting. So here is a nice clip of the IVC running through the liver here at the top of your screen. And one of the things that I'll point out is that it's very easy to confuse the inferior vena cava with the aorta. And if you stick to some basic principles, it will make it very easy for you to be sure that you never do that and make a measurement of the wrong vessel. So one of the things that I will note is that the inferior vena cava should always drain into the right atrium, which is sort of that fluttering structure you're seeing here on the left side of your screen. The inferior vena cava also always is the recipient of the blood flow from the hepatic vein, which you can see here draining down into the IVC. And there should never be a vessel draining through the liver into the aorta. And so once you visualize those two structures, you can be relatively confident that you're visualizing the inferior vena cava. This is also important because of where we measure this vessel. The cardiology guidelines that we use in the United States recommend measuring about 1 to 2 centimeters away from that entry point of the hepatic vein. And we'll be discussing how to make sure that you have visualized that in the right location. But the key markers are draining into the right atrium, having the hepatic vein drain into it, and then as you see it sort of transcending the liver and moving up across your screen, those are helpful markers that can guide you to be sure you're not confusing it with the aorta. The other thing is just to remember that we had discussed once we have visualized this vessel, there are so many things within the body that can influence how it is impacted and how it looks. And so we've discussed that intra-abdominal pressure, where it's somebody who has abdominal compartment syndrome, somebody who has had a trauma, patients who have a large body habitus, that have external pressure on their abdomen. All of these local factors can certainly influence the IVC diameter, but also things such as intrathoracic pressure, which we'll spend a little bit more time discussing on my next slides. And then the right atrial pressure, as we discussed, and as Dr. Al Saud discussed, in the setting of cardiac tamponade, when you have fixed pressure around the heart, that is going to reduce the ability of the heart to receive blood coming from the inferior vena cava, and thus the IVC will be dilated. And so it's very important to remember that this vessel, as it traverses the entire body, is really going to be susceptible to the structures around it. And so the first thing to think about when you are doing an ultrasound of IVC is to think about whether or not your patient is breathing spontaneously or if they're mechanically ventilated. And so we will first talk about patients who are breathing spontaneously. And the most important thing to remember is the physiology of inspiration and expiration. And so when we inspire, we decrease our intrathoracic pressure. And as we decrease intrathoracic pressure in the lungs, that makes it easier for the blood to come back from the IVC into the right atrium, and thus you increase venous return. So when you increase venous return, the IVC diameter, by nature of that, gets smaller because all of the blood is making its way back into the heart for circulation throughout the body. And so when we inspire, the IVC should be more collapsible and the diameter should be lower in a spontaneously breathing patient. Alternatively, when we expire, you increase intrathoracic pressure, and thus you decrease venous return. And when you decrease venous return, the IVC diameter should go up. This is normal physiology. And so in a normal patient who's breathing spontaneously, there should be expected variation between inspiration and expiration in the diameter of the inferior vena cava. And this is called the caval index or the collapsibility index. There are some people who have spent time thinking about whether or not there's a specific number that matters in that setting, and we'll get into that later. But just to note that that percentage of difference is the one that matters when in a patient who's spontaneously breathing. And so that's what you're seeing here is that when we inspire, the IVC collapses, and when we expire, it is more distended, and this is normal. In patients who are mechanically ventilated, and so for those of you who practice emergency medicine or in the critical care setting, a lot of patients will be mechanically ventilated, and often they'll be quite sick, and we will have questions about their volume status and the need for fluid resuscitation in these patients. And the thing to remember in that setting is that as a patient is mechanically ventilated, by nature of providing them positive pressure, we are manipulating their physiology such that they lose that natural variation between inspiration and expiration that we expect in a spontaneously breathing patient. And so we are taking that variation away, and by providing, for example, PEEP or positive end expiratory pressure, we are making this curve flat. And so a patient who is mechanically ventilated often will have very minimal IVC distensibility or variation as in the respiratory cycle. And that's in an euvolemic, mechanically ventilated patient. However, a patient who is mechanically ventilated who is hypovolemic, because we are providing the positive pressure throughout the respiratory cycle, you will get an inverse relationship of what you see in a spontaneously breathing patient, such that you will see with inspiration, the IVC becomes more distended, and with expiration, it is more collapsed. And that suggests in a patient who's mechanically ventilated that they could be hypovolemic. That's called the distensibility index. And so in patients who are breathing spontaneously, it is collapsibility. As you see here, it's collapsing down with inspiration. And those who are ventilated, it is called the distensibility because it is more distended with inspiration. It's the same formula, it's just the number in the denominator that changes. And it's just to remember that when we manipulate physiology, we have to think about how that changes our calculation. And so if we know that it changes with inspiration and expiration, it becomes important for us to think about, well, how do I actually find the IVC? And what you're seeing in this view is a patient who's being ultrasounded with the curvilinear or abdominal probe. You can also use the phased array cardiac probe, but often it's easier with the curvilinear. And we're centering the right atrium in the center of the screen, and then making a 90-degree rotation with the probe marker so that it moves from being focused towards the patient's right up into their head. And we will show in the next screen a picture of what I just said, but center the right atrium, rotate 90 degrees, and then you will see here a structure that comes across the screen that drains into the right atrium, which you centered. Here's the right atrium, here's the hepatic vein coming into the IVC, and then down here is the aorta. And I put this picture up because it demonstrates how easy it is to confuse these two vessels, but how those first principles that we discussed of identifying the inferior vena cava can make it quite easy to be sure that you're not confusing these two vessels. And then you would measure again about 2 centimeters down from that entry point of the hepatic vein into the IVC. In terms of mechanistically how you actually do that, here's a probe marker that is oriented towards the patient's right. Then the ultrasonographer rotates 90 degrees up towards the patient's head, and they do some fanning and maybe a little bit of sliding in order to bring that image that we just showed into view. And so it's pretty easy once you have initially identified the subxiphoid view, essentially, to center that right atrium and then rotate 90 degrees. There are certainly other ways to do this. This is just one, and it does depend to an extent on which probe you decide to use. The question then becomes, how do I know if the IVC is collapsible or distensible? And to be honest, quite often you can eyeball it without even needing to do fancy measurements in M mode. This is an IVC that is clearly collapsing all the way down. This is one that throughout the entire respiratory cycle is quite distended and enlarged. And so in that setting, you may say, well, this patient has a collapsible IVC. I wonder if they would do well with a fluid challenge. And in this patient, you might say, wow, it looks like there could be a lot of volume in this IVC. I wonder what is going on. But this is again to remember that there could be other factors driving these, and it's important to think about this in the context of the patient. And so in terms of if you are going to formally measure this, this is what is called M mode on the ultrasound. And essentially you are just measuring the point of maximum and minimum distensibility. And then you take the max minus the min and divide by the max. And that gives you something called the cable or collapsibility index, which we already talked about earlier. And then remembering that if the patient were mechanically ventilated, you would be using the reverse in the denominator. And so if we have established that the IVC to an extent could reflect the CVP, we would hope that IVC as a predictor of our surrogate marker of volume status and the CVP or the right atrial pressure would then predict whether or not a patient would be fluid responsive. And when this has actually been studied, this is a pretty well-respected study in the EM literature surrounding point-of-care ultrasonography and the IVC. And what they found is that if the IVC is measured at less than 2.1 centimeters and is collapsible, that usually correlates to a right atrial pressure or a surrogate for the central venous pressure of being 0 to 5. And if it's greater than 2.1 and less than 50% collapsible, this is all spontaneously breathing patients, then it should be about 10 to 20 centimeters. Or millimeters of mercury. Everyone else sort of falls in the middle. But the issue is when this is tried in real life, what we've actually found is that you get essentially a random number generator when you try to use CVP to predict fluid responsiveness. And so while yes, to an extent, the IVC may predict the CVP, it does not, in fact, predict whether or not the patient will do well with a fluid challenge. Because the issue is that patients who have reduced ejection fraction in a continuously distended IVC can also be hypovolemic, they can still be septic, and they can still be volume down. And so in these patients, when they were measured, the CVP was measured, there was really no correlation between that and their need for fluids or their volume overload status. And so to an extent, this proves that the IVC as a unifying sort of measurement that can support whether or not you should give a patient fluid, that would be an incorrect use of this modality of ultrasound because it doesn't quite work the way we had hoped it would, likely because of all these factors we mentioned that influence the IVC diameter. And so then people tried another angle to see if the IVC could just itself predict fluid responsiveness in the absence of even using a CVP formally measured. This was during the time that the Rivers protocol was really gaining traction in the critical care literature. And what they found is that patients who responded to fluid challenges were essentially they sort of were a widely varying population, and that to an extent, we cannot simply predict fluid responsiveness exclusively based on IVC because as you can see, these patients fall completely across the curve. And so to an extent, patients were more likely to have a collapsible IVC if they were fluid responsive, but patients who had a dilated IVC still in fact also were fluid responsive. And those often were those heart failure patients who get infected or have other issues that cause them to be volume down like I previously discussed. And so it's a little bit confusing because we have this marker of perhaps volume status, or at least to an extent of the central venous or the right atrial pressure, but it has never been proven to consistently as a marker in isolation predict which patients will do well with a fluid challenge. And so this is my last few slides here, just on one proposed protocol in terms of how can you integrate IVC ultrasound and those information and those points that we have about distensibility and collapsibility into the actual care of a patient. And if we first of all isolate the patients who are on the outside of our realm of measurement, so patients who are clearly underfilled, their IVC is less than 1.5 centimeters, that's significantly less than that 2.1 centimeter threshold we discussed. It is probably going to be safe to give them crystalloid and to do a fluid challenge and to see how they do. The patients who have a significantly distended IVC with over 2.5 centimeters and no variation, it is quite likely that they would not do well, or you would not feel great about aggressively giving them volume. And so the patients who are on the far ends of the spectrum, the answer is a little bit clear. And sometimes you don't even need ultrasound to answer that because you know just based on your clinical assessment. But in the patients who have an IVC that's in the theoretically normal window, 1.5 to 2.5 centimeters, the question then becomes, how can I narrow down which of those patients actually might do well with volume using this information I'm getting from IVC ultrasound? And we would like to suggest that perhaps the patients who are intubated and who are not breathing spontaneously, you can calculate that IVC distensibility, and if it's over 30%, you can also try fluids in them, and you probably won't hurt them, although it's not clear that it's necessarily going to help them. But the patients who are not intubated and who are breathing spontaneously, but have a normal IVC diameter, and you're really not sure about their fluid status, their lung ultrasound can help to guide you. And in the next lecture, you're going to be learning about B-lines and how we think those are helpful in predicting volume status. So if a patient is not intubated and has a normal IVC, but their lung is full of B-lines, you may be hesitant to give them a lot of fluid and put them in the fluid restriction category. But if their lungs are totally clear and they have a normal IVC, they also may be a patient population where you'd consider doing a fluid test. And you can see then how in this paradigm, the IVC ultrasound essentially helps you to risk stratify your patients when used in correlation with their cardiac and lung ultrasound to decide whether or not they'd benefit from a fluid challenge. And so the takeaways are that a small, very collapsed IVC probably won't hurt the patient with fluids. If there's a plethoric IVC with no variation, maybe you shouldn't give them fluids, but you should consider the circumstances and think about what their lungs look like as a safety net. And so the IVC, as we said, is a structure that is extremely susceptible to pressure, to volume, changes to hemodynamics. The physiology, I think, is actually quite fascinating. But at the end of the day, it's just one data point in a large series of questions that you can answer with ultrasound. I hope you found this helpful. This is my email address. I think I went a minute or two over. So if there are not time for questions, you can certainly feel free to reach out. Thank you so much.
Thank you, Kathleen, Dr. McFadden. I feel like every single time I hear the IVC lecture, I learn something new. It's like, wait, I'm probably doing this wrong. So thank you for all of that information and for the literature. It's always good to kind of back up what we are doing in the clinic or in the hospital with science. So thank you, Kathleen. I think that shows she's the internal medicine doctor out of every one of us. So do we have any questions? I know that there were some questions in the chat about the prior lecture. And I know that there might be some questions now because right now we have like a 15-minute break. But before we go for break, I want to make sure that we are able to answer some questions. I guess somebody had asked a question about if we measure pulmonary pressure with ultrasound, and I tried to answer the question. So there are some advanced modalities to kind of approximate that pulmonary pressure, but really the science for, if you're concerned for a PE, we are looking at right ventricular strain. So we're trying to see if there's that D sign that Dr. Alsawood had explained as the flattening of the septum, and if the right ventricle is larger than the right, if the right ventricle is larger than the left ventricle. We have a hand raised. Benga, do you want to unmute yourself and then ask your question? Benga, I think you can unmute yourself.
Yeah, I did that.
Okay.
Can you hear her? She doesn't.
What's your question?
Question for the comment on the VEX score and its applicability in the emergency department. That's for Kathleen.
Oh, Kathleen. Yeah. Can I ask a question?
With regard to the VEXUS score, I don't personally spend a lot of time using it. I know that they sort of determine grades for the IVC and then use things like the flow patterns as well. We sort of consider the advanced flow patterns within the hepatic circulation a little bit beyond the point of care setting in terms of how we answer our yes/no questions in the ED. We did actually recently have a conference on this where we discussed it as like a realm for possible further research in the EM setting, but currently here clinically, to my understanding as an internist, but within the emergency room as well, it's not really used all that often. I don't know if any of the others who practice EM agree with that.
Yeah, I can tell you as an EM doctor here, I have never used the VEX score and probably will not ever. But I'm sure there's some research and practicality that it can be used for. I wanted just to mention, somebody had asked about the probe marker. So I'm just going to, so we have an ultrasound here. I don't know if you can see, but the probe marker is like this extra indentation on the screen. So that's what the probe marker is. And most probes have this kind of like, it could be a thickening or it could be an indentation. And that's how you know what your orientation is. I don't know if you can see the screen here, but this here is a probe marker right here. Oh yes, and then if you use the gel, if you put the gel on, then it will tell you from the screen where your probe marker is.
I think you also wanted to know the correlation to the side of the body, the probe marker and its correlation to the body. I think that's what the person wanted to know.
Okay, so
Maybe it will be difficult to.
That is going to answer that question.
If you guys could look at me, not any images there. So the concept is if you get a probe and you put it on the person's body and you have the marker is on the right. So if you think about it in patient's orientation, it's a bit confusing. So the way to do it is like, this is the marker, it's on me. And when you look at the screen, it's on the left side of the screen, but it needs to match. So if you hold this against the screen, match the marker to the marker. That's the easiest way to do it. Forget if it's left side to the patient or right side to the patient. Take the probe with the marker, match it to the screen. It's going to be the same side. This will help you like when you're going towards in a way with the orientation. I hope that helped. To not let it be confused because it's left side, right side of the patient.
It's like when you an X-ray. You know, when you do X-rays, right, left, yeah. Oh, I'm unmuted. Okay, yeah. Okay, good. Okay, great. So I think we have a break now. Let me just see what time the break is over. So we have a break for about 15, now for about 6 minutes. I think that we can come back at, it will be 2:35 for us here, and it will be 6:35 for GMT. So we'll come back at 6:35. Enjoy your break, have some food or snacks or walk.
Guys, if you're going to have the break, please do not sign out. Just close the video and the screen and mute yourself.
Is your mic on?
Mhm.
It's only special request.
Can you hear it?
Yeah, you unmuted. There you go. Someone's
Hmm? Okay. So how do I can hear you?
Yeah.
Fresh on the beat.
Ferrari look good on you. Bugatti look good on you. Gucci look good on you. Louis good on you. Like, I see what goes on. I want to hear this from you. Girl, I want to know. Say you go there for me, yeah. If I did drink daddy, yeah. Say you go do all the things where you say you go do for me, yeah. If I not get the money, oh, yeah. Say you go stand by me, yeah. Say you go do all the things where you say you go do for me, yeah. You know that, I know that. My love for you no get pattern. Primary do like some sort. Sing it out loud anyway that I know. My mommy, oh, my daddy, oh. Soon you go miss you, my baby, oh. Somebody. For your mother, I go kiss somebody, oh. You know this love something, not a joking thing. Baby girl, you know something. Say somebody to somebody, oh. For your mother, I go kiss somebody. Is it me and you, mommy, oh? Is it me and you, mommy, oh? Ferrari look good on you. Bugatti look good on you. Gucci look good on you. Louis good on you. Like, I see what question they like. I want to hear this from you. Girl, I want know. Say you go there for me, yeah. If I did drink daddy, yeah. Say you go do everything where you say you go do for me, yeah. If I not get the money, oh, yeah. Say you go stand by me, yeah. Say you go do all the things where you say you go do for me, oh. I'm just asking you a question. Mommy, you don't need to vex you. If this wasn't my position, say you go give me your best, you. I love you, girl, no be baby. You know for sure you're my baby. I'll be awake when you sleeping, just to make sure I'm not dreaming, not dreaming now. You know that I love you, baby. Do anything for you, baby. Ferrari logo down you, Bugatti logo down you, Gucci logo down you, Louis go down you. Let me ask you one question, me want to hear this from you. Batman one do, girl I want to. Big sponsor.
Dr. Dollar Entertainment.
Everybody's gonna win, yeah. If only you just believe.
Okay.
Dr. Dollar Entertainment.
صح صح oh my god صح انا ابو الاسد والله مصر.
Welcome back, everyone. Hello. Everybody can come back so we can go back to the schedule.
لما تبدأ تحكي سوي شير سوي شير
Okay. What's your name? Okay. Okay. Hi, everyone. We are going to go back to schedule so everybody can have the rest of the evening. So our next lecture is going to be on lung ultrasound. We have Dr. Mariam Ibrahim Al-Alumi. Anoemi. She's a Jordanian emergency medicine physician. She completed a fellowship in assimilation at the Brigham and Women's Hospital here. She's our current fellow. She's also faculty at the Sheikh Khalifa Medical City, which is a hospital in Abu Dhabi. We are very glad to have her here with us. So you can share your screen.
Can you guys hear me? Yeah, we hear you loud and clear. Okay. So
No,
thank
you are. There's a mute.
Here.
Okay.
Go ahead.
Okay. So good evening, everyone. Good afternoon for us. Yeah, you're okay. Okay. So my name is Miriam, and I'll be talking about lung ultrasound. We will start first with an introduction. Let's just go from here to there. Okay. Okay. So basically in lung ultrasound, we have multiple uses in the ED. We can use it basically for EFAS, which is an extended fast scan, whether we're checking for hemothorax or pneumothorax. We can do it for pleural effusion, pneumonia, and pulmonary edema. I'm going to cover basically hemothorax and pneumothorax and pleural effusion, and then Dr. Lusapla will cover the rest in the next session tomorrow. We start basically with the techniques. It's about how, what type of probe are you using and how will you do that? There's two probes that we can use when it comes to lung ultrasound, and it depends on how deep you want to penetrate the chest cavity. If you want to look out for the pleura, then you can just take the linear probe. And if you want to check the lung itself, then you have to take the curvilinear probe. So what's the difference between them? For the linear probe, you have a high frequency. It gives you a straight arrays, and it has a higher resolution. So it's quite good if you want to check for any lung slidings of the pleura, and if you want to check for a pneumothorax. While for the curvilinear probe, it is low frequency and it shows low resolution, but it does penetrate deeper. That's how the images will look like when it comes to ultrasound. So that's how would you differentiate it if you're checking a video on a machine. So as you can see here, the linear probe shows it as a line basically on the screen, while the curvilinear shows it as a curve. Okay, how can we make it easier? And how would you scan, and what will people see on a machine if they're not seeing the patient? Is how basically you will divide the zones of the chest. You can divide them either anterior, lateral, and posterior, or you can just divide them by number, which goes from 1 to 8. And then if you want to scan the posterior for a pleural effusion, we'll get to that. It's very useful basically to do the scanning, to do the zoning, just to make sure that you're marking it on the right side, just like when you say you have a pneumothorax on the right side of the chest, it's marked as an R on an X-ray. It's the same, basically, you mark it as a 1 on an ultrasound. It's also beneficial for the sake of research. So transducer has to be perpendicular to the skin. So you're basically putting it on a 90-degree to the skin, and you have to stay still. Why is that? Basically just because the lung is moving, and to have a good picture, if the lung is moving, then you have to hold a picture still on the screen just to make sure that you're capturing the right movement. And a positive scan goes for a 2 positive zone in each hemothorax. So 1 or 2 positive means you have a pneumothorax, basically. And that's how it will look like. 1 second. Okay. So this is how a normal lung will look like. Now, if you can see, there's actually points here. Like you can see that there's a reflection of white areas around this area, and it doesn't show anything, or actually it just multiple layers of white artifacts, we call them. So these are air artifacts. What does it mean? It means that the lung is infiltrated fully with air, which is what we want to see. So that's how a normal lung will look like on an ultrasound. Whereas when it comes to a lung that is filled with fluids, which is it will show you as an array of light, which basically means that the lung is not as normal as we see it in this slide. So this is the air being haphazard all over the lungs, while here you have it concentrated on specific areas where the fluids are. So this is basically B lines, and I'm not going to talk about this. Dr. Lutaplo is going to cover it by tomorrow. Again, B lines is basically pulmonary edema or any interstitial fluids in the lung. So this is a comparison between A lines and B lines. Of course, it's always good to know the normal just to differentiate when it comes to the abnormal. That's in motion. So that's B lines, how B lines will look like. And that's A lines all over. Okay, pleura on ultrasound. Now, when it comes to pleura, the pleura is attached to the lung. So when the lung is moving with the breathing, then the pleura will move on top of it. Now, if there's an air trapment outside the lung, there's going to be a space between the lung and the pleura. So when the lungs move, the pleura wouldn't move. And that's basically what we're trying to scan just to make sure that there's no lung sliding. How would lung sliding looks like? You see the shiny shimmers on this side, that's the line of the pleura, and that's basically lung sliding. So as you can see here on this side, there is shimmering lights on a line, which is the pleura, which is a normal lung. While in this image, you can see that there is a shimmering light, but it's not moving like this. Let me check if I can play it again. 1 minute. There you go. Okay. As for pleural scanning, it's really good to put it on an M mode. As Dr. Lutaplo mentioned earlier, M mode can give you a specific imaging on that specific exact position that you're pointing, and it can show you as in lines later on the scan, which is basically like this. So this is how a normal lung will look like in an M mode. You put your probe, you see the lung, and you press the M mode, and it gives you a seashore sign. This is an image that tells you that the lungs looks normal, the pleura looks normal, it's sliding normally over the lung. While here, when the pleura is not sliding on top of the lung, it will show you a different the shape of the image, basically. And that's what we call it a barcode sign. Barcode signs means everything is standing still. There's no movement of the pleura, which gives you that kind of artifact on the on the ultrasound. That's how different it looks like in comparison to each other. So normal lung will give you the seashore sign, while a pneumothorax will give you barcode sign. Okay. We'll talk next about the pleural effusion. So pleural effusion comes in multiple types. It can be complex and it can be simple. We have to know that any type of pleural effusion, which is fluid, will show black on the ultrasound. So knowing that, then you have to know that it can show you multiple septation, and it can be complex, homogeneous, or heterogeneous on an ultrasound. But as long as you know that it's going to be black on a screen, that's going to be your way to know. Let me show you where will you scan. So an X-ray is not very sensitive to small amount of pleural effusion, just because basically the patient is sitting and the pleura is the effusion might accumulate at the back, so you wouldn't be able to appreciate a huge. You will not appreciate a small amount of fluid. You can appreciate it when it gets enlarged. Where would you scan? You will basically scan on the posterior aspect, and as the gravity pulls the fluids down and the air up, so you have to scan on the costophrenic angle, basically. So you will go to that area, and you should basically get an image of your right upper quadrant. It gives you the liver, and that's the kidneys, and that's the diaphragm. So behind the diaphragm is the lung. And this is a sign that we usually look for. It's a mirroring sign. What does it mean? It means that the diaphragm acts like a mirror that reflects the liver into the lung. And they all seem like a same contrast. While when you lose the lung contrast in here and it turns black, that means there is a pleural effusion. And I'll show you in here. So that's the diaphragm, and that's the lung now, and that's the fluid. So there is loss of mirroring in here. Another image is here. So you see, this is the liver, and that's the diaphragm, and that's the collapsed lung, and all of this is fluids. In motions, that's how it would look like. It's a huge amount of fluids, basically, and the lung is collapsed in the middle. This is another video I found interesting just because there is septation. I'm not sure if it's clear. So there's a lot of septations, again, in the same area when you're scanning, and it doesn't give you a lung image. Whatever things that happens and gather here is going to be a pleural effusion. So in here, there's a lot of septation. So that's not a simple effusion that you might drain in the ED, but it means that there is a pleural effusion that's compressing the lung. So summarizing it all, these are basically all abnormal images. The first one is the B line, which we don't want to see in a normal lung. The second is the non-sliding of the pneumothorax. And the last one is the large pleural effusion that we just mentioned. I think it's very important to know the normal, so you can look for the abnormals. And of course, when it comes to lung ultrasound, it's more sensitive than chest X-ray. It's more specific and more accurate. So it can actually tells you if the patient is in an urgent need of a tube or thoracocentesis or chest tube. And based on the depth, basically, you can tell which probe would you choose, and if you're scanning the lung or the probe or the pleura. All right, then. So any questions? Thank you, everyone.
Thank you, Miriam. Thank you for going through that and giving us an introduction to lung ultrasound. You kind of gave us like an appetizer to what will be coming tomorrow. So thank you for that great introduction. I think somebody had a question about showing a normal lung and lung with I think the question was here. Can you show again the comparison between normal pleura and pneumothorax?
Of course. 1 second. I don't know how to. Okay. So you want it in the arm mode, or so this is how it is. 1 minute. So that's the sliding. And here, there's no sliding. You can see that there is no movement of the pleura.
Yeah, I know that sometimes I think about it as normal pleura looks like ants walking on a line.
Yes.
And then for the pneumothorax, you don't see that motion.
That's a very good way of saying it, yeah.
Do you want to show it for
M
M
mode
mode as well?
Yeah. So this is the normal lung and M mode, which is the seashore. It looks like lots of dots, while if it looks like a barcode, then that's mean there's an pneumothorax. How about this one? This is probably better. Okay. Shall I answer?
Yeah, I think, yeah, thank you for answering those questions. Does anybody have any more questions about lung ultrasound? Okay.
Okay,
Well, we're going to move on to our next lecture. Our next lecture is going to be given by Dr. Rachel Vivian. Dr. Vivian is a fellow here in our division of emergency ultrasound, and she's an examiner for the Royal College of Emergency Medicine in the UK. So we are so glad to hear Rachel's talk, and her talk is going to be on abdominal free fluid.
Thank you, Ani. It's a pleasure to be here. Okay, no, just. So, welcome to your talk on abdominal free fluid. In this talk, we're going to cover what FAST is, what does it stand for, what question does FAST answer, why do we use it, when is it indicated for use. We'll also cover a bit about probe positioning and the technique used to obtain optimal images. And then we'll look at some normal scans and some abnormal scans. So the question we want to answer with the FAST scan is there free fluid or blood in the abdomen? FAST stands for Focused Assessment with Sonography in Trauma, and that's because it was initially used to look for free fluid or blood secondary to traumatic injury. However, as time's gone on, we've realized that there are other causes of free fluid in the abdomen that FAST can be used for. So its use has become a bit more than just trauma in the ED. When is it indicated? Well, obviously for trauma, blunt or penetrating, or it can be used for trauma or abdominal pain in pregnancy. For example, ruptured ectopic pregnancy would show free fluid in the abdomen. It's also used as an adjunct for unexplained hypotension in any patient. For example, a ruptured AAA would also show free fluid. Now, there are 4 views to the FAST scan. Those are the right upper quadrant, the left upper quadrant, the pelvis, and also the subxiphoid view of the heart. I'm not going to cover the subxiphoid view of the heart in this talk because that's been covered earlier by Ahad, but you should remember that that is part of the FAST scan. You may have heard of something called an eFAST or an extended FAST. That's a more recent development where FAST is now being extended to involve the upper zones of the lung to look for lung sliding, which Mariam's just told you about, checking for pneumothorax. Again, I'm not going to cover that again because it's already been covered. So in this talk, we will focus on 3 zones in the abdomen: the right upper quadrant, the left upper quadrant, and the pelvis. In the right upper quadrant, the probe should be located in the mid-axillary line at the level of the costal margin. You want to orientate your probe so that it's parallel to the ground with the marker facing the patient's head, as such. So head at the top, and then feet at the bottom, and then the mid-axillary line. See the costal margin as well, and the head of the marker at the head. This is the image that you'd like to obtain. you want to see the liver. Thank you. I'll use this one here. So it's a picture of the liver, the kidney, and the diaphragm. These are the areas that you need to see. Now, in the right upper quadrant, you must see the hepatorenal interface, or Morrison's pouch, which is a hyperechoic line between the liver and the kidney. You also need to see the inferior pole of the kidney, or the tip of the liver. And you must also see the diaphragm. This is because fluid tends to accumulate in these places. Now, in Morrison's pouch, which is a hyperechoic line, the white line, it will appear black. Okay, the free fluid will appear black in all areas, but in Morrison's pouch, you will see a black line. You should never see a black line there. There should not be free fluid in that area. It should be white. Sometimes this white line, the hyperechoic line, can be thickened due to perinephric fat, and some people confuse that with free fluid. But if it's not black, then it's not free fluid. Okay, so here is just some information showing the anatomy: liver, kidney, diaphragm. We'll see the shadow of the vertebra. Okay. Moving on to another slide. This is just an image showing a normal view. I don't think they're quite getting the inferior pole of the kidney, so this would be an inadequate scan. But you can see they've got the Morrison's pouch and the diaphragm, but there's no free fluid there from what we can see. Although you'd have to say it's an indeterminate scan because you can't see the inferior pole of the kidney. Here's another picture just showing free fluid, quite obviously, at the tip of the kidney and the liver. Okay, so fluid will appear black, pointy and triangular when it's free fluid. Anechoic area. Okay, and then this one here, but you can see, this is why it's so important to get the inferior pole of the kidney, because just at that little triangular area there, at the tip of the kidney, there's some free fluid. For the left upper quadrant, similar idea to the right upper quadrant, except obviously you have a spleen rather than a liver. The spleen is also a lot smaller than the liver, so you have to slightly change your position. You're still around the mid-axillary line area, but you'll probably have to go a bit more posterior and slightly more towards the head. Your probe should still be parallel to the ground, and the marker should be facing the patient's head as such. So posterior midline, level of the costal margin, marker pointing towards the patient's head. Now, these are where you start. Obviously, that's where you should position your probe. You may well find that you have to adjust your angle slightly. Everyone's anatomy is slightly different, but this is just an idea of where you should start. And once you can see an image, adjust it so you can see all of the areas that you need to visualize. Here's a picture of what you should see. This is a spleen and the kidney. Now, the interface between the spleen and the kidney is much smaller than the liver and the kidney because the spleen's a lot smaller. So it's not so crucial to see the inferior pole of the kidney on this view, but you must see the tip of the spleen because fluid can tend to accumulate here. So the three areas you must see on this view are interrogate all around the spleen, including the spleen of the tip of the spleen. You want to see the splenorenal interface, similar to Morrison's pouch on the right side, and also the diaphragm. And here's just they're just looking at showing some free fluid here. You can see just all around the spleen, actually, at the tip of the spleen, and you can see it above the spleen as well, this black area. Okay, and kidneys just coming into view here. For the pelvis view or the suprapubic view, your probe needs to be located just above the pubic symphysis. It needs to be really quite low in the abdomen to get the bladder. Your probe should be orientated with a marker facing the patient's right, to begin with, a transverse view of the bladder. And you should fan up and down so the bladder comes into view and then disappears completely from view. And then you should rotate your probe clockwise so the marker is facing the patient's head to obtain a sagittal view of the bladder. And then on this view, you want to also rock your marker from side to side in order to interrogate the area around the bladder. And again, the bladder should come into view and it should disappear from view when you're doing this. So I've got a video just showing that movement. So that's a transverse view, just angling upwards and downwards to get the full image, and then rotating round and then angling from side to side to make sure you get all around the bladder. Here's a transverse image of the bladder. You'd be looking for fluid around here. Around the outside it tends to accumulate, but obviously it can accumulate anywhere, but anywhere around the bladder, you want to see areas of kind of triangular pointy fluid. That's free fluid. There's no free fluid on this one, this is normal. This is a sagittal view of the bladder. You can see there is free fluid here. This area here, this anechoic or black area. Okay, so just to summarize the views that you need, like I said, we're not talking about the subxiphoid view of the cardiac view, you would need to get that, but for the three views we've talked about, right upper quadrant, left upper quadrant, and the pelvis, in the right upper quadrant, you need to see Morrison's pouch, you need to see the inferior renal pole, and you need to see the diaphragm. In the left upper quadrant, you need to see the splenorenal recess, you see the caudal tip of the spleen, and you need to see the diaphragm. And in the pelvis, you should get a transverse view of the bladder too, but you should also get a sagittal bladder view and make sure you fan from side to side. So you're going through all around the bladder. Now, there will be times where it's not possible to obtain every single view that you need. And it happens to the best of us. You know, it can be due to body habitus. If someone's very obese, it can be due to abnormal anatomy. It can be due to bowel gas. So sometimes it can be tricky. And if you really cannot get a view, you just need to write that your scan's indeterminate. So for example, if you have a right upper quadrant view and you manage to get a view of Morrison's pouch, and if you can see that there's free fluid in Morrison's pouch, then you can call that a positive scan because you've seen the free fluid. However, if you've viewed Morrison's pouch and there's no free fluid, and you've seen the diaphragm and there's no free fluid, but you just can't see the tip of the spleen, then the tip of the kidney rather, excuse me, then you cannot call that a negative scan. Okay, it needs to be indeterminate, and that's fine. Then perhaps you'll go on and get other images, or perhaps, you know, you'll get a more experienced practitioner to have a look. But just don't call it a negative scan if you haven't viewed all of these areas. So here's some tricks if you are struggling to get images. You can sometimes the rib shadows get in the way, and for the right upper quadrant and left upper quadrant. So just slightly rotate your probe to try and get a better image. For the left upper quadrant rather, you really need to have the probe to the bed. Your hand is almost on the bed when you're trying to get this image. Make sure you do interrogate the tip of the spleen. If you have a cooperative patient, then you can ask them to take a breath in. Sometimes that will help the organs come into view. And just remember, the bladder can really be quite low, so you do need to get quite low with the probe. Here's just some more images to have a look at. You can see there's some obvious, this is a sagittal view of the bladder. You can see there's obvious free fluid here. Triangular area, play to the video. So here we go. They're fanning from side to side. So the bladder's going out of view, coming back into view. Okay, we have a view here of the right upper quadrant. Again, quite obvious marked free fluid here. So this is liver, this is kidney. Just play this again if I can. I don't know if I can. Yes, okay. Playing again. Here we go. So there you go, obvious free fluid. So what do we do with a fast scan? So I found a sample clinical protocol that was developed by Scalia and his friends. They're a group of experts that came up with a protocol as to what to do with a fast scan. It's not actually based on any research, but it seems very sensible, so I thought I'd discuss it here. So basically, it depends on whether your patient is stable or unstable. If you have free fluid, then I guess it's a lot easier because you've got a positive scan, and you need to do something about it. So if the patient is stable, you'll probably have time to get a CT scan to actually delineate what exactly is going on. Now, whilst FAST is great for looking for free fluid, it's not very sensitive for detecting what actual organ is injured. A CT scan will be much better for doing that. If your patient is unstable, it's probably not very sensible to send them to the CT scanner. So in this case, they probably need an emergency laparotomy to explore what's going on and repair what's been injured if it's a trauma. For a negative FAST exam, it's a bit more tricky here, I guess, although it can be reassuring in some ways. If the patient is stable, then you may just observe them for a while. And the good thing about ultrasound is that it's non-invasive, so you can repeat it. There's no radiation involved, there's no risk to the patient. So you can watch the patient, you can do further FAST scans, hourly if you want to, or more frequently than that, I guess. And you may find that free fluid does develop after a while, or you might get some further imaging, depending on what the symptoms are. If the patient is unstable, then it would probably be worth looking for other causes other than intra-abdominal causes for hypertension. You may well, if the patient still has symptoms of abdominal pain, then it may be worth getting a surgical consult anyway. It should be noted that FAST is, if it's positive, it's pretty sensitive. However, it's pretty good. It's not perfect. So if it's negative, sometimes retroperitoneal blood isn't always seen. And also you do need to have a minimal amount of fluid, free fluid, to be detected. I think they say the average practitioner is probably about 500 mils, which is quite a lot. It depends on how good you are at it. Some people can see it at 100 mils. But this is just an idea of what to do with your scan. Okay, thank you very much.
Thank you, Dr. Vivian. That was an excellent talk on abdominal free fluid. It was like so clear, so precise. I was just so engaged in your talk. Well, thank you. Does anybody have any questions? So somebody just asked, is it possible to detect a retroperitoneal bleed with a FAST exam? So
if you can see free fluid, then you can rule it in. In fact, it's rule in, not rule out. So if you see free fluid, then yes, you can say that you've detected it. If you're suspecting a retroperitoneal injury and you can't see free fluid, then no, you cannot rule it out. You need to get further imaging.
Any more questions? Thank you again, Dr. Vivian. Really great talk.
My pleasure.
Okay, to finish us out for the day is our fellow extraordinaire, Lauren Salemi, Dr. Lauren Salemi, who is coming to us from Jefferson and is here now as a fellow and will also be joining the faculty at the Brigham in like a few months. The Brigham is a neighboring hospital that we have here. She's very interested in medical education and ultrasound education. So we are very excited to also hear her speak. And she'll be talking about aorta, so ultrasound and aorta.
Thank you, Onyi. 1 second while I get this to come up. Okay, great. All right, can everyone hear me? She said yes. Yeah, okay. Okay, it sounds like everyone can hear me. All right, so we will be talking about bedside ultrasound of the aorta today. We're going to go over some normal anatomy, aneurysms, and dissections. So these are our objectives, essentially what we just said. We'll also, of course, go over the bedside ultrasound technique in doing this procedure. So first, just kind of looking at a picture of our standard aorta. This is the aorta, and we have all the major branches that come off of it shown here as well. And then we'll bifurcate into the two iliacs. Some things to note, there are 3 vessels that come out at the aortic arch. Then we're going to come down through the thoracic aorta, get to the diaphragm. Once we reach the diaphragm, we switch into the abdominal aorta. And then a few vessels come off in the abdominal aorta. In thinking about the thoracic aorta, the left subclavian artery may be important if you're trying to differentiate between type A and type B dissections, but that is very difficult to discern by ultrasound. So usually we're just ruling in dissections, not ruling out dissections by ultrasound. And on only some occasions can we tell if it's a type A dissection or not. And then there's 2 arteries here. These are the renal arteries. These are important when we think about abdominal aortic aneurysms because most aneurysms are actually beneath these 2 arteries. Unfortunately, we don't always see these arteries on ultrasound. So we use some of our other anatomy like the SMA and the celiac artery. Celiac comes first and then the SMA to help us make sure that we start scanning the aorta before the renal arteries take off. And then, so what is an aneurysm? You all know it's a dilation of the aorta. As of the dilation, that's classified as an aneurysm will differ by where you are in the aorta. So greater than 4.5 centimeters in the thoracic aorta is certainly an aneurysm. Some citations may even say 3.8 centimeters is an aneurysm. But once we get to the abdomen, everyone generally agrees that greater than 3 centimeters is an aneurysm at any point of this aorta, or you can use cutoffs of greater than 150% of normal or greater than or 1.5 times the proximal aorta diameter. The aorta should be smaller as it traverses down the abdomen. So if it's larger at the distal aorta, then that may actually be an aneurysm. And as we said, most aneurysms are infrarenal. Also, most of them are fusiform in shape, which means kind of the whole aorta circumference is dilating, but in some cases, they're just saccular aneurysms. Thinking about the risk factors for AAA, you all know most of these, but just to refresh our memories, since we need to keep them in mind when we figure out who we should do this scan on. People more than 65 years old are at risk of this. Male sex, Caucasian are at greater risk. Smoking, hypertension, hyperlipidemia, COPD, connective tissue disease, family history, and fluoroquinolone use. That is by no means an extensive list, though. Those are the biggest ones. But what is the greatest predictor of rupture in a AAA? That would be size. And most AAAs that rupture are greater than 5 centimeters. It's important to note that 1 out of 12 patients that have a AAA greater than 5 centimeters will have a rupture within a year. So it is a pretty deadly diagnosis if you find it for someone, and it requires very close monitoring and surgical intervention as the size will increase by 1 to 3 millimeters per year. And how do we diagnose AAAs? So I think first we'll screen when it's clinically indicated. We'll suspect it in patients with risk factors or symptoms of a AAA, and then we'll do our physical exam to palpate maybe a pulsatile abdominal mass. But how good is physical exam? Actually, of course, we're going to find out it's not that great, but it is 68% sensitive. That's almost surprising to me, but that means we're missing a lot of patients. Sensitivity does increase as the aorta increases in size, but it will decrease with greater abdominal girth. Unsurprisingly, since this is an ultrasound talk, we're going to look at some studies that I think these are both single center studies, but they're pretty large, and they show that abdominal ultrasound of the aorta is actually 100% sensitive and with a pretty high specificity as well. So it seems like this is a really great examination. Looking at what we do in the US, here, actually any man over the age of 65 who has ever smoked is recommended to have a screening ultrasound of the aorta, even without symptoms, because most aortic aneurysms are asymptomatic. So we want to try to catch these patients. So this is done as an outpatient, though some may argue that you can do it in the emergency department too. And then what do we do with these numbers? Patients that have aortas less than 3 centimeters don't need any monitoring, but it's really once we get to that 5 centimeter cutoff that we start considering surgical consultation. So, and by 5.4 centimeters, any patient really should just have elective repair. Although any patient that has a symptomatic aneurysm really should have a surgical consultation as well. So going through the clinical indications for this exam, undifferentiated hypotension, syncope, age greater than 65, especially for men, any belly pain, flank pain, back pain, and lastly, the pulsatile abdominal mass. Now, how do we do it? First, you're going to use a low frequency probe. So there's two options for the low frequency probe. We can use the curvilinear here, or we can use a phased array. For the abdominal aorta, it is preferred to use the curvilinear, though you can use the phased array for any part of the aorta. For the thoracic aorta, it's typically the phased array that's used. The patient will be in a supine position, and you're going to use graded pressure starting at the area of the diaphragm in the center of the abdomen in order to find the aorta. Generally, that graded pressure will help you displace bowel gas, and that gas will often get in the way of the aorta since sound waves don't travel through gas, but pressure will help you see the aorta. If you're having trouble because there's just too much tissue to get through, you can try moving the patient to the left lateral decubitus position to displace their pannus, or you can use lateral positioning of your probe, generally a little bit to the left, since the aorta lies on the left side of the body, to get away from some of that bowel gas and the pannus. You can also ask them to bend their knees. This will relax abdominal musculature. As well, you will get a view of the aorta that may look something like this. This is an operator sweeping down the aorta. And we're going to go through everything that we're seeing here. So first, looking at the proximal abdominal aorta, there's 3 structures that you'll see in every image and will help you make sure that you're certainly looking at the aorta and will help you communicate with others that this is the aorta. And those 3 structures are first at the bottom of the screen. So the farthest away from your ultrasound probe is the vertebral body. So this looks hyperechoic on the ultrasound machine, and then there's posterior shadowing. So that means it's bright white on top, and then it's kind of gray or black beneath it. As we know from anatomy, the aorta travels along the vertebral body. So the aorta is seen on the vertebral body, though sometimes it's a little bit to the left. And then to screen left and patient right of the aorta is the IVC. In the proximal aorta, the first vessel that comes off the aorta is the celiac axis, which will include on screen right, the splenic artery, and on screen left, the common hepatic artery. Of course, they're going toward their respective sides. The spleen will go to the left side of the patient and the common hepatic artery to the right side. The left gastric artery typically is not seen on ultrasound. This image is often referred to as the Siegel sign. And to take a proximal abdominal aorta measurement here, we'll freeze the ultrasound image, and we'll use calipers to measure the size of the aorta. And we measure from outer wall here to outer wall here. If you can't see the walls well, it's always best to kind of over measure so you're not missing any aneurysms. This is an image of the proximal aortic, So we have the vertebral body here. It's bright white and gray beneath it because we can't see past it. And then we have the aorta right here. It's pretty circular and thick-walled, and it's pulsating. There's the celiac artery that comes off of it, and this is our Siegel sign with the 2 vessels. The IVC is actually, it looks like right here. You have to be careful because the IVC will kind of look like it's pulsating just because it's right near the aorta, and it also has respiratory variation. So it moves a lot. This is all just to say, make sure you know for sure you're looking at the aorta. And you can use the vessels around it to help you differentiate between IVC and aorta. Okay, coming just slightly down the proximal aorta, we see our next vessel come is the superior mesenteric artery. There's a couple of vessels that traverse around here. It's not too important to know exactly what they are, but I think recognizing this space is very important. So this is the splenic vein that comes above the superior mesenteric artery. It dumps into the portal vein, and beneath the SMA, we have the left renal vein that will come across. This image is often referred to as the mantle clock sign, and that's just because the SMA and the surrounding fat tend to look like a clock face. And as I said that this spot in the aorta is very important, it's because the renal arteries come off very near to here. So you want to make sure that you find this area so that you know you start your exam at least before the renal arteries, because beneath the renal arteries is where most aneurysms are. Again, we'll measure from outer wall to outer wall. Here's an image at that spot. So we have our vertebral body. This is kind of the anchor of every aorta ultrasound to make sure that we have the vessel that's above the vertebral body of the aorta. This is the SMA. This is that mantle clock sign. We have the splenic vein, and beneath SMA is left renal vein. The renal arteries come off soon after this. Here's a measurement at the level of the SMA. We're going from outer wall. So this kind of a little bit hyperechoic area is the wall, and we're going from outer to outer. There's a little nutcracker on the screen, and that's because there is a clinical pathology that takes place in this area. That's nutcracker syndrome, when the SMA compresses the left renal vein and causes dilation of the left renal vein, flank pain, and hematuria. I think it's nice to keep in mind these syndromes just because it helps us remember the anatomy that we see, and for clinical practice, of course. Now coming down the mid-abdominal aorta, we're just going to track down using graded pressure to watch the aorta the whole way down. This is the measurement we'll take, outer wall to outer wall. And at some point, the SMA will kind of disappear from our screen. Here's an image where we're just tracking down. Right. And then finally, the distal aorta. This is the area right leading up to the bifurcation to the iliacs. And it's very important to scan until the aorta bifurcates into these two iliac arteries, because that assures that we saw the entire aorta. This bifurcation happens around the umbilicus or around L4. Because it happens at the umbilicus, sometimes you will have to just kind of angle your probe when you're still above the umbilicus so that you're not scanning over the umbilicus, because then you'll have an air interface and won't be able to see anything. The measurements for the iliac arteries should be less than 1.5 centimeters. Here are some images of the bifurcation. All right, and then these are our measurements. These are the two iliac. Next, the longitudinal aorta. In order to get this view, we're gonna have we're gonna be visualizing the transverse aorta in the center of our screen. So have the transverse aorta kind of right here, and then we're gonna rotate our probe 90 degrees clockwise so that the probe marker is facing the patient's head or cephalad, and then the aorta will be elongated along the screen as such. You'll be able to see some of the vessels coming off the aorta, the celiac and the SMA you'll see, and you may see the vertebral bodies beneath it. This will help us make sure we didn't miss any aortic aneurysms, and of course that we also didn't miss any dissections. Here's an image of the sagittal aorta or longitudinal aorta. This is the celiac artery coming off, leading to the common hepatic and the splenic artery. And then we can see the SMA right here. The operator is trying to rock the probe in order to make the aorta go just horizontally across. because of the lordosis of the spine, the aorta will kind of travel a little bit more anteriorly as it comes distally with the spine. And there's another clinical syndrome that happens around here. This is SMA syndrome, when there's an acute angle of the SMA and it will kind of compress on the duodenum, causing SMA syndrome. This is like Nutcracker syndrome, not something that we're going to diagnose with these ultrasounds, but just something to think about when we look at this anatomy to help us remember what we're seeing. And in this image, we're actually using a phased array probe here. You can tell by the footprint, it's just a V. And we're fanning between two large vessels in the body. This one's the IVC, which goes through the liver and up to the RA. And then we see a little glimpse of the aorta. This is the aorta coming down, and you can kind of see the celiac and the SMA on the aorta. This is just to say to be careful and make sure that you're scanning the right thing when you're scanning the IVC or when you're scanning the aorta. And so we take transverse measurements from outer wall to outer wall. And then some people might consider, should I take a longitudinal measurement? I would say to be very careful if you do this and really just to not do it at all. So if you think about the longitudinal measurement, if you were to be off axis, not in the center, then you may accidentally be on the side, and then you from outer wall to outer wall and under measure the aorta. This would lead to missing aneurysms. So I would advise only take measurements in the transverse and then switch to longitudinal to make sure you didn't miss any aneurysms. So these are the minimum criteria we use here at our hospital. Some hospitals will choose to do this a little bit differently, but I think doing at least this is certainly the right thing. So you want a full sweep through the entire abdominal aorta. You want to measure from outer wall to outer wall at the largest diameter of the aorta. And then you want to visualize the bifurcation to the iliacs and take a longitudinal view of the aorta as well. So we're going to go through some cases. This is to just kind of give you a sense of the magic you can do with ultrasound in order to diagnose patients a lot quicker. So this is a 65-year-old man with belly pain and hypotension. So he clearly meets criteria for an abdominal aortic ultrasound, and one is performed. This is a curvilinear probe. This is our probe marker. So this is the patient's right. And over here, we actually see this large structure that becomes larger as we're coming down the abdomen. So this is the aorta. The lumen looks very irregular and it definitely looks large. This is the vertebral body here. So this is a large aortic aneurysm. It has signs that look concerning for rupture as well, although ultrasound is poorly sensitive for identifying aortic rupture. So in this symptomatic patient though, you would definitely just want to great access, start transfusions and get surgery at bedside. Any delay to getting the surgeons at bedside and getting the patient to the OR will have very large effects on your patient's mortality. So getting the ultrasound in your hands and diagnosing this will really do a number for your patients. And just to reiterate, aortic ultrasound cannot be used to rule out aortic rupture. And similarly, FAST exams cannot be used to rule out aortic rupture. Since the aorta is a retroperitoneal structure, you generally shouldn't have a positive FAST even with an aortic rupture. Here's another case. This was a 60-year-old guy that came in with flank pain. And here we have a still image of an ultrasound. You haven't had your renal tox yet, but you'll learn that this is a kidney. And this is actually hydronephrosis. So there's something backing up the flow out of this kidney. And since this is an aorta talk, of course, this is an aortic aneurysm. that's compressing the ureter, causing flank pain for this patient. So this is a patient that's symptomatic with an aortic aneurysm. Here, this whole area is the aorta. Here's a small area of lumen, but there is this intramural thrombus. So in measuring this aorta, you want to make sure that you're actually measuring from outer wall to outer wall. If you were to only try to measure from inner wall to inner wall, you'd miss 50% of this measurement. Here's a sagittal view of that aortic aneurysm. So we're sweeping into the aorta and we see this large fusiform aneurysm. All right, so this is a 55-year-old patient. She has hematemesis and mentions some history of a stent, but doesn't tell you much more. And quickly an ultrasound is done and you find this aorta. So this whole area is the aorta. We see something beating in here. These hyperechoic areas, these are all actually the stent. So this is an endovascular repair, which with an intramural thrombus. Then over on this side, we see the stent continuing down into the iliacs. So this is a large aneurysm, and the patient's story is very concerning for an aortic enteric fistula. Again, someone that should go to the OR and hopefully more rapidly because you used ultrasound. 68-year-old man that comes in with belly pain. This is the vertebral bright white with posterior acoustic shadowing. And then we see the aorta above it. We actually see the two renal arteries coming off. We don't always see that, but we see that right here. And we don't see any signs of an aneurysm. But you don't want to be tricked. The operator switched to the sagittal view and found this distal aneurysm. So if you don't sweep through the whole aorta, you're at risk of missing aneurysms. This is a clip of that distal area. So the operator is making sure that they scan the distal part of the aorta and assure that they got to the bottom by seeing the iliac bifurcation. That's about 3.5 centimeters when it's measured. And this is a tall 19-year-old male. He came in with tearing chest pain that lateralized to his left chest. This is his abdominal aorta. And we see something very different about this one. First, starting with our basics, again, we see the vertebral body here and shadowing beneath, and above it, we see this aorta and we see the IBC. To the left, screen left, patient right. But there's a hyperechoic structure within it that seems to be flapping. And then we see it on the sagittal view as well. So this is an image of a dissection. As we know, it's a pretty rare diagnosis, but it is one that you never want to miss and one that has a high mortality. I'm thinking about what is that hyperechoic flap that we're seeing. Well, it's the parts of the aorta that have been split. So we develop a false lumen and a true lumen. And then this part here, which is the intima media, would be the hyperechoic, or just the intima, sorry, is the hyperechoic flap. Similar to aortic rupture, you shouldn't use ultrasound to rule out this diagnosis. It's only really used as a rule-in test. The FAST, again, should generally negative. It's about like 10% of cases happen to have a positive FAST, but this is retroperitoneal, so the FAST should be negative, so don't let it reassure you. It's also difficult to determine if it's a type A or type B dissection. These are the risk factors. I think family history and connective tissue disorder are big ones. And then bicuspid aortic valve actually leads to a 9-fold greater risk of dissection. And trauma and cocaine are two ones not to forget that are not talked about very often. So looking at the thoracic aorta, We're going to use the phased array probe. This is that probe marker that people have been talking about. There's a little button, not button, but knob that you can see right there. And here are some images. So this is a parasternal long axis view. And here we see the left atrium goes to the left ventricle and then comes out through the aortic outflow tract. This is the aortic valve, except this aortic outflow tract just looks very large. So this is a thoracic ascending aneurysm. This is the descending aorta that looks okay. But if we look at this one, this is also a parasternal long axis view. The aortic outflow tract looks normal here, but the descending aorta is huge. So that's the descending aneurysm. And then there's another image, it's called the suprasternal notch view, that can be accomplished by placing the phased array probe at the suprasternal notch while the patient is laying supine and has their neck in extension. And your probe marker has to face up to about 7 o'clock so that you're keeping in mind that the aorta is coming out through the front of the heart and then going down the back so that you can catch the aortic arch, which is seen right here. And then you can sometimes see the 3 vessels coming off of it. You can see one here, another one here. If you were to see a flap in here, then you would rule in a type A dissection. Though you do not always see the flap, so sometimes you can look for secondary signs like aortic regurgitation or a pericardial effusion. And for thoracic aortic aneurysms, the complication rates just keep increasing with increasing size of that aneurysm. So at a certain point, either 5 or 6 centimeters, depending on the patient's risk factors, it's recommended to just get these fixed by surgery. And any patient that has one of these aneurysms and is symptomatic should be seen by your surgeons. So for final points, bedside ultrasound is very sensitive for AAA. So I think it'd be wonderful to incorporate it more in all of our examinations. And for renal, AAAs are most common. We want to measure from outer wall to outer wall. Greater than 3 centimeters is a AAA, and we can't use ultrasound to rule out dissection or to rule out rupture. These are my references. And this is actually the QR code that we'd like everyone to use to take surveys to give us feedback about these lectures. If you have the opportunity to scan this now, that would be wonderful.
Thank you, Dr. Selami.
Almost.
But that was a great talk. I feel like every time I hear the aorta lecture, my heart always beats fast because it's the one thing that you never want to miss in the ED because the patients can do very badly. Like we've definitely seen some patients like crash in front of us because of a dissection. So thank you so much. So we have, so as Dr. Selami said, this is a QR code for the lecture. This is day 1. So if you use your phone and just use your camera, and this will take you straight to the link. We will also send you, does it echo? No. Well, okay. Yeah, so we will also send you a link in an email as well. For the survey for day 1, there will be 2 surveys, one for day 1 and one for day 2. If you take the survey for day 1, you will get an automatic email for the survey for day 2 at about 3 hours after the lecture is done, kind of plus or minus. Okay. And then at this point, I'm going to let Chris give us some final thoughts, and then we can ask some more questions if you guys have any more questions. Lauren, you can stop sharing. Chris, you are muted.
Allowing me to unmute.
Okay, now you are good.
Okay, thank you very much. Yeah, it's been a wonderful section, and I think a lot of people enjoyed it, and the participation and the contribution from everybody who took part has been wonderful. The presenters too have been very, very amazing from all continents, I'll put it that way. And I think those of us who did not have enough, what they call it, knowledge about ultrasound, we're lucky to have been introduced to how the ultrasound works. And well, later we cruised to the lung, the aorta, fast, cardiac. We've done quite a lot today. And I believe a lot of people appreciated it. And if you didn't appreciate it, I'll just urge you to keep practicing it. If you have an ultrasound in your department, you just have to keep practicing it. It's very, very useful point of care ultrasound. And in this COVID era, if you don't want to get too close to the patient, and I think it's going to be a very useful adjunct to try and make your diagnosis. And even when it's COVID, I believe tomorrow we'll have a chance to learn about it. We're going to find using ultrasound very, very, very useful. And the skill is going to be very, very important if you want to be very, very good clinicians. And well, I remember going into the COVID zones with full PPE, and I asked myself, how am I going to use a stethoscope to listen to the lungs? It's not going to happen. So, well, if you have an ultrasound, well, you have a way out to try and make evidence-based diagnosis. So I thank you. I don't know whether I can mention all your names, from Dr. Andrew, Al Saud, Vivian, Lauren, and anybody that I couldn't remember, but I think we are very, very grateful. Kathleen McFadden, yes, I have to remember your name. All right, thank you, everyone.
Thank you, and thank you, Chris, and thank you everybody at CAT and everybody from all over the world. We have people here from Ghana, from Nigeria, from Ecuador, from Brazil, from Ethiopia, from Boston here, just everywhere. And we look forward to seeing you all tomorrow. And the course will start tomorrow at about the same time. So we'll start around 1:10. We'll have a 15-minute break as well, and then we will end around this same time. Do we have any last minute questions before we leave for the day? Yeah, 5. Yeah, it will start. I'm sorry, it will start at 5 p.m. your time, 5 p.m. GMT. Sorry. Okay. Any last minute questions? So somebody just asked, what tricks can you employ? You can send this to the group, but this was sent to me directly. What tricks can you employ to optimize the image of the aorta for obese patients or patients with bile gas? Lauren, do you want to take this one?
Hey, everyone. So for obese patients, the first step is always just the graded pressure to slowly keep increasing the pressure that you're using on the patient's abdomen to try to see deeper. Usually with graded pressure, you can do a lot more than you think you can, and patients can tolerate that pressure even when you think that they cannot. If you're still having trouble, then you can move the patient to the left lateral decupitous position to get the pannus out of the way. So you're going to decrease the depth to the aorta, or you can try moving your ultrasound probe a little bit to patient left, kind of like here, to visualize over there. But some patients, you're just going to keep having trouble and you may have to get a CAT scan.
Awesome. Somebody asked for the QR code. I'll just, let me see. I'm just going to share my screen to the, oh yeah, great, awesome. So that's the QR code. Well, if you want to stay and ask us some more questions, feel free, but today's agenda is over. Thank you for coming.
Thank you, everyone.
Thank you.
You happy?
Can you hear it? You can hear it? Okay. People waiting. Oh, people are so happy. It's good. People are like, oh, God's blessing. Some people were in the return.
God
Yeah,
bless.
everybody likes it. Such nice.
Baby, 1+1 now you only when you chop at you she knows it. Now you had to wake to call in the midnight. Come on, oh. Give me all love now, baby. Doesn't get in my eye, you make me go. Never have you no letting go. 9 to 5 just to make that. Don't worry about I go fight kung fu. Get in my eye, you do want to. And for your love, I go die. Baby, oh yeah, make me do. I'll never rather stop meeting you. Baby, 1+1 now you. Only when you chop at you. Baby, oh yeah, make we do. I'll never rather stop meeting you. Baby, 1+1 now you. Only when you chop at you. Girl, I go die for you. Open the soft, open the heart, and the hot, and it's up to you. Yeah, so I call my mom and they were so shy. Definitely bring it back to you. Pass me your love, girl, I'm asking you. How do you feel when I'm kissing and touching you? Just for them know what it does to you. Breaking my back for you, nobody else but you. Me the whip it'll be 1+2. Put on a cabin, one down the love tattoo. And then collab, this love not true. Been around the world, no one like you. Can't wait till the day we go say I do. Girl, you be the lace when they tie my shoe. Everybody say hi to it, clear my crew. Baby, I am make it true. I'll never rather stop me and you. Baby, 1+1 now you. Only when you chop at you. Baby, I am make it true. I'll never rather stop me and you. Baby, 1+1 now you. Only when you chop at you. Baby, my eyes make me go. Never have been no letting go. 9 to 5 just to make that. Don't worry about I go fight kung fu. Baby, my eye, you do want to. For your love, I go die. Baby, I make we do. I'll never rather stop me and you. Baby, 1+1 now you. Only when you chop at you. Baby, my eye, you do want to. For your love, I go die.
I'm going to end now.
You're gonna end it? Oh, okay. The end. Thank you, Doc.
Lectures were so good. It was really great. Like, great stuff on top Oh, really? You sing
Skeleton,